And actually the first talk is actually kind of quick. And what my real task was is try to explain to you what some of the problems are that your nephrologist has when they're trying to figure out, first of all, what your diagnosis is, but then second of all, what to do about your diagnosis. And so just put your hat on as if you're the nephrologist for this discussion, really, because that's what I want to go through and do. Very good. Very quickly, I want you to become familiar with what the challenges are that the nephrologists face for you. We're going to review the stepwise approach to treatment and where I'm calling them bumps in the road are for each of those. And then finally, very briefly in this discussion, we're going to talk about the options for escalation of your care, or what does your nephrologist need to think about when they're thinking about escalation of care. So this is the road that you're on, right? It's not straight at all. It's got lots of bumps. It's got some downs and it's got some ups. And so that's really what we want to sort through. And to do that, I'm going to actually use one of our actual patients. I asked his permission. He's a 21-year-old male. He presents with lower extremity edema. He is found to have blood in his urine and a low C3. So those are the classic presentation features that not everyone has them, but that's pretty classic. He happens to have 10 grams of urine protein. Normal is 200 milligrams. So he's got a lot of urine protein, and he also has an albumin of 1.9. So those features right there actually should make you fairly comfortable with worrying about at least whether the patient has glomerulonephritis, and that's enough for that doctor to want to do a biopsy. That's really the easiest point of everything we're going to go forward on here. So when they do the biopsy, they discover C3 dominant glomerulonephritis, and you've been introduced to this terminology already. But really what I want you to see is that's what the pathology report should say. That's what it will say. But what are the problems that your nephrologist has if he or she gets that diagnosis? And in fact, the very first question that I think now should pop into your mind based on what Richard had mentioned to you earlier is this C3 glomerulopathy the disease instead of just a histologic finding that the pathologist has discovered? So the first point, it's really easy to declare something as C3 dominant glomerulonephritis. And in fact, the point for this particular slide is that C3 dominant glomerulonephritis does not necessarily equal C3G. And why is that? Well, first of all, your nephrologist has to consider this possibility of at least 30% of post-infectious glomerulonephritis patients will be C3 dominant glomerulonephritis. And again, this is because I'm also a pediatrician, that 85% of the children who come into my clinic with glomerulonephritis have post-infectious glomerulonephritis. So it's a very common finding in pediatrics, children who actually have a glomerulonephritis. So of course, statistically, it should stay at the top of your list to at least think about for the vast majority of patients that present with C3 dominant glomerulonephritis. Then there's the complicating feature that C3G can masquerade as immune complex GN. And we're not going to spend a lot of time on that, but there may be some of you in the room that have carried the ICGN or immune complex MPGN diagnosis, but then someone later switched it up on you and you now have C3G. That's actually not as uncommon as you might think. And in fact, in our population, it's easily 12% of patients will do that. And some of the publications that have been out there, it's 8 to 10%. So it definitely can happen. And so you can see that this is one of the problems that your nephrologist is going to have if you get a biopsy that is not completely, that fits into this complement-mediated kidney disease spectrum. Then there's the issue of nonspecific C3 deposition is actually, unfortunately, quite common. And I really throw up these three only because these are the three that have been published. There are others, and I apologize, I'm causing extra sound, but there are others. But the point is that when it comes, if you have very late stage CKD, So very near end-stage kidney disease. Often there can just be some non-specific C3 deposition that in an unsuspecting pathologist or local nephrologist, it may look like C3 dominant glomerulonephritis, but if they don't pursue exactly where we are in the stage of disease, et cetera, it could be confounding for them. And then it happens in diabetes, it happens in FSGS, that there can be 1+ or such of isolated C3 deposits. And so each of those your nephrologist has to consider. So really the question here becomes immediately, was there a recent infection? So what's the problem with that question? Even if it was a legitimate post-infectious glomerulonephritis, up to 30% to 40% of patients won't remember what that infection was. It will have been mild enough that they don't even register it. So even if they say no, they did not have an infection, that does not rule out post-infectious glomerulonephritis. So again, your poor nephrologist has really got a lot of things building up in front of him right now. I want to go over very quickly what the diagnostic criteria is. You've already been introduced to that, but again, I want to share with you some of the problems with the diagnostic criteria, which we helped create, but we recognize that there are some problems with it. So first of all, as you know already, it's 2 times more C3 on the biopsy than other immune reactants. That's pretty straightforward. Oh, actually, the point I wanted to make about that, what if your pathologist says there's 2 to 3+ C3 and there's trace to 1+ IgG there? So it's not technically 2 orders of magnitude different. So that's the problem is that there is some vagaries involved in actually being able to call whether something is 3+ versus 2+. If you have 4+ only C3 on the biopsy, that's great. But very frequently we have a smattering of C3 and something else, and whether you can declare whether it's the full 2+ difference or 2 times different can actually be somewhat difficult. So what about that patient who had the infection? The only way we can move them, if it's C3 dominant on the biopsy or even C3 isolated on the biopsy, the only way we can move them from post-infectious glomerulonephritis to C3 glomerulopathy is if at 12 weeks they still have a low C3. And that criteria is actually in the guidelines or in the consensus statement. So that's the truth. If it's abnormal at presentation, normal in 12 weeks, you're supposed to call that patient post-infectious glomerulonephritis. And the obvious reason to be very specific about that is because if you declare someone as post-infectious glomerulonephritis, that should be more of a transient disease. That should be a disease that you get over. That should be a disease that doesn't recur again for you. So it is quite important. Here's the problem for your nephrologist. We all have had patients that normalize their C3 at 16 weeks. Or 19 weeks, but they never recurred again. So they truly were post-infectious glomerulonephritis. They just didn't read the textbook and know that they were supposed to normalize at 12 weeks to make everyone's job easier, right? But that happens a lot to us. Really, the point is that that's what the guideline says, but there is still some slush in being able to actually interpret that. And then finally, what about the patient that presents with a normal C3? Because they present after the 12 weeks, then you don't get a chance to figure out what they had before because nobody tested it. And now you're stuck with a normal C3. So again, that's something that your nephrologist actually has to sort through. What we do in practice is that if at, let's just pick a number, 7 months, if it's 7 months past presentation, they still have very aggressive glomerulonephritis, the creatinine is still not in the normal zone, the urine protein is still quite high, we're willing to say, we don't know what the heck happened before, but at this point at 7 months, we're willing to call it C3G. But you can see that it can be a little bit confusing trying to sort through all of that as you're going through the process. And then finally, I want to mention, though, as you know, obviously, Moral is incredibly committed to and appreciates very much the biomarkers. They are not part of the diagnostic criteria. So you don't have to have a low C3 to have the C3G diagnosis. You can have it with a normal C3. But to flip that around, you will never be able to rule out post-infectious glomerulonephritis unless you're watching it. the C3 that is. So you can see again the dilemma that your local nephrologist might be facing if you don't have at least some of the very basic biomarkers to watch that they went into the normal range. And again, in coming year or years, we will have better publications even from our group on the significance of the biomarkers, and it will become more black and white for you. But right now, at the very least, if you're not watching the C3, then you could be actually missing something. So let's say you've committed to the C3 glomerulopathy diagnosis. You've decided your C3 dominant glomerulonephritis actually is C3G. The next question that your physician has to sort through is, what are the next steps? Well, it doesn't surprise you that I'm going to probably throw another curve in your highway, if you will. But the short answer is you can begin supportive cares anytime. That's appropriate for post-infectious glomerulonephritis patients with high blood pressure, or if they have high urine protein, or if they have very active disease, et cetera. You can actually start, ACE inhibitors, ARBs, all of those things that we would classically consider supportive. You can start those at any point. You don't have to be 100% committed to this being a C3 glomerulopathy diagnosis. So your local nephrologist may be already considering that, starting something. But here's your bump in the road, though. When do you start immune suppression? So they have to now figure out when to start immune suppression. And there is expert guidelines for that. So I'll share with you what the expert guidelines are, but I will remind you that there also can be some local policy differences in when to start immune suppression. But the expert guidance is that if your patient continues to have greater than a gram of urine protein, so again, 200 milligrams is normal. If they have greater than a gram of urine protein, you're technically supposed to start immune suppression. So if you are going to start immune suppression, what are you going to use? So that's the next dilemma for your nephrologist. And in fact, also guideline-based, not randomized controlled trial-based, and that's important for you because that means that there are definitely going to be differences in patients' response, and we don't know how to quantify that other than I'm going to share with you some cohorts here. But mycophenolate mofetil, or here in the US, most often Cellcept is used, or Myfortic, and prednisone are the primary choices for you actually starting of your therapy. Now, these were based on other glomerular diseases. They actually had nothing to do with C3G as an initial choice. But again, I'll show you a couple of the cohorts that actually inform that. But the question that your nephrologist really faces, it's not so much the when to start. Most people are comfortable when to start over a gram, makes sense to them. It's how long to stay on the steroids. And I will tell you right now, there is absolutely no data to inform this question. Generally, pediatric practices prefer to do less steroids than adult practices do, but glomerular disease centers across the US, I'm not sure even about how it would work in Europe, but glomerular diseases across the US have very different approaches. Here at Iowa, we do 12 weeks of steroids, period. If you need more steroids, we are immediately searching for a steroid-sparing regimen. We're looking for some other drug that we can use instead of using steroids. That's not that we know that we have the right answer. We just know that there isn't any data to go 16 weeks or 2 years. So we opt for the shorter duration and then see if we can find something else to use. Here's a very quick summary of the data, and really because I know that the print can be kind of small for you, what I want you to see is that red is 0 response in these cohorts. Green are the patients that actually responded to the mycophenolate mofetil and steroids. And again, they used the mycophenolate differently. They used a different course of steroids in every single one of these studies. So this is a very messy piece of data, if you will, or a messy group of cohorts. But the point is, at least 30% of patients will respond to that regimen. And that's why the guidelines recommended that we start there, because it's better than 0 response going forward and continued loss of kidney function. So when do I escalate care if I'm on Cellcept and prednisone? Well, it probably won't surprise you that it goes back to the 1 gram. If you're on Cellcept and prednisone and you still have more than a gram of urine protein, you should escalate care again. This is where it gets really even stickier, if you will, for your nephrologist, because Here's the big question. What do you escalate care to? I'm just going to go very quickly through these three because we have tried B cell therapies. Those are drugs that actually try to destroy B cells. B cells make nephritic factors. So that's the reasoning behind that. It just turns out in the vast majority of reports that have been published, it hasn't worked. And we also don't have a fantastic experience with that here at Iowa. Plasma exchange, where you actually exchange someone's plasma for fresh frozen plasma from the blood bank. That actually does make sense also because you're removing those nephritic factors, for instance, and you're putting back non-nephritic factor plasma. It actually does remove the nephritic factors, and you actually can quiet the complement system down, but you can't possibly keep up the plasma exchange as often as you're going to need it to keep the nephritic factors gone. So again, it can be an acute fix for some of you, but it's not going to be a long-term therapy for the vast majority of you. And then finally, terminal complement blockade. And I know obviously that has been the only complement inhibitor that we've had available to us. So it is the one that we have used, but I want to sort of discuss why it might not be a perfect a choice for many patients. And you may have already guessed why it might not be based on what Richard presented to you earlier. And in fact, I'm just going to use this. I know that's very small print, but so let me just skip through and say, in this particular study, which is from the French group, they had 6 patients with complete remission. So these are patients that urine protein went away, the GFR or the creatinine stayed stable or improved. 6 patients out of 26. 13 happened to be children, 13 happened to be adults, so that's good for our audience. Then they had another 6 that had a partial remission. So in fact, it turns out that somewhere around 40% of patients will actually respond to eculizumab. The problem, and again, there's no data to support this in a global way, if you will, but the problem is, and this was presented, someone mentioned, actually it might have been in clinic, so maybe a lot of you didn't hear it, but the point is that it has been published that people respond to eculizumab, but this response is not lasting. Or there are patients that have responded to eculizumab clinically, but when you repeat their biopsy is worse. So there are still some problems with the eculizumab response data. But again, to be completely fair, it does work in some patients. We absolutely have had complete remission in some patients. The problem is we don't know how to tell who that is. We don't know how to tell who would be better suited with that medication versus something else. So that's really the problem. And then this is the cartoon I use to try to go through that very quickly. And basically, I'm just going to go through the 2 that are mycophenolate, for instance. If I give you steroids and mycophenolate, what do I think I'm doing? I think that I'm addressing the anaphytoxin activity that actually happens. Mycophenolate's not a direct complement toxin or a direct complement targeting agent, right? But we think we're blocking those anaphytoxins. If you block those anaphytoxins, in theory, you can reduce the proliferation on a biopsy, and the proliferation on biopsy is bad. So that's what we think the mycophenolate is doing. How about if we use terminal complement blockade? And functionally, this could be eculizumab or ravulizumab, or there's another one that I'm drawing a blank on the name, but it could be one of those terminal complement blockers. And in this case, what you're doing is you are blocking the C5a anaphytoxin, but you're also adding the extra component of blocking the terminal pathway. The problem for us in that particular circumstance is we don't know which patient the terminal pathway is driving disease, because as Richard has shared with you, the vast majority of this disease appears to be at the amplification loop, at the level of the alternative pathway, not the terminal pathway, the alternative pathway. So where we see the convertases, where we see those nephritic factors being active, where we see all of those problems happening, if you will. So that is at least our theory about why our current approaches are not as good as we would like them to be. So this is my last hook in the road, or last bump in the road. And basically, what if everything that I'm trying that I can prescribe for you is not working? What is your nephrologist supposed to do about that? Well, should I encourage a clinical trial? Well, I will tell you, and Richard has already introduced this, and I'll talk more about it in my next talk, but we have tried to do every single trial that comes out so that we have a sense of exactly what works, what doesn't work, et cetera. And again, I'll bring this up late, in a few moments. There is one trial coming that we couldn't do for logistic reasons. That's coming up. But right now, there is no trial for the adult patient with C3G to enter into. There just isn't one available. I will encourage you to go to clinicaltrials.gov or contact Monica or Rebecca or somebody on our team, and they can help keep you posted about what trials are available. But right now, there isn't a trial for adults. There is intermittently a trial for children as the drug iptacopan is actually being tested in children, but they're admitting 5, watching for 3 to 4 months, admitting 5 more, watching for 3 to 5 months. So it may not be one that's available to you. Keep your eye out. Q32 is the one we're aware of that actually is coming. We can talk about that afterwards. What about an alternative access program of some kind? Well, is that a good idea? I will share, you know, again, because I'm a pediatrician and most of you know, or probably know this, a lot of medications we use in the hospital have never been tested in children. I use drugs in the neonatal intensive care unit to control blood pressure. They've never tested them in neonates, but we do a lot of that because we have to. That is not the future of medicine though, right? The future of medicine is making sure that we've tested everything in children. It's certainly at least in the population that we're going to be treating. And why is that? Because until we actually test it, we don't know if it's going to work. We don't know if it's safe. Certainly trying to go outside of an approved mechanism is very costly, very labor intensive to make happen. And I'm here to say that it can happen. And, you know, you can talk to our teams and find out that we are doing it. But these are the reasons why it can be very difficult to do it. And really, we should keep efficacy and safety at the top of that list. We don't necessarily know if things are efficacious and safe. So here's the last slide for this group. So when you're on a journey, when you're on that highway, what do your children say? Are we there yet? And you say back, oh, we only have one more stop, even if it's 250 miles away, right? Our goal is to convert that to that. That's what our goal is. So that you can get your diagnosis quickly. We can treat you fairly quickly with what you need, as opposed to something that might work, might not work, so that you go into remission. That's really our goal. And what we're hoping to do is push those bumps in the road way down the road so that maybe the question is, can I come off? What's next in your care can be well past you actually being in remission. And towards that end, and the next talk that you're actually going to hear, there have been 2 phase 3s. So you may recall, if you listened to last year, phase 3s are just before FDA approval usually. So these 2 phase 3s are now complete. They will, we presume, approach the FDA, get approval, et cetera, et cetera. So we are actually hoping that something might happen for us in 2025 that at the end of the day moves us closer to having that sort of picture. Thank you.